So we're going to be talking about some fun stuff. Diseases. And we're going to start with the obstructive lung diseases. Three most sort of characteristic: post-child, chronic bronchitis, emphysema, and asthma. So the problem in obstructive diseases is that the respiratory passages are, as we can get from the name, obstructed. Am I clear? So, which means that people cannot efficiently expel the air from the lungs. So they have to expire forcefully and actually inspire forcefully. The main risk factors for all obstructive lung diseases in the United States is smoking. Generally speaking, any type of environmental pollution increases the risk for obstructive pulmonary disease. It can be professional, work exposure, people who say work in the mines and exposed to thin aerosols often develop emphysema. People who live in large cities are larger risk for lung diseases. For instance, I was growing up in a city which is basically like a Soviet space city. So we had the Mission Control Center and still have a bunch of manufacturing, facilities that made actual spaceships, rockets, rocket fuel, and they tested all of it. And when I was growing up, not having respiratory disease meant that something wrong with you. So basically every kid in the city had some respiratory problems. And then in the late 80s, when all of this started to crumble, those companies, didn't work as much, and the entire city got healthier right away because the air got better. Okay. So a lot of those diseases, the obstructive pulmonary diseases, have similar symptoms. Dyspnea, which is when you make a conscious effort to breathe. Okay. Coughing and pulmonary infections. Now, coughing arises from the chronic inflammation of the upper and lower respiratory tract. When you try to expel mucus that accumulates as the result of that inflammation. And respiratory infections are the direct result of increased accumulation of mucus. Normally, mucus is expelled by cilia, moved by cilia towards the larynx. Does that make sense? And then you swallow it. However, if mucus cannot be moved, or it is too much of it, or cilia are damaged, mucus becomes a trap for a pathogen and often sort of a welcoming medium for their reproduction, and people have pulmonary and lower respiratory tract infections. Hyperventilation, acidosis, hypoxemia, all those symptoms, that's for a really bad situation. Now, what happens in emphysema? Due to the environmental factors or smoking or sometimes genetic disease, connective tissue in the lungs is broken down and alveoli are destroyed. Now, when we say destroyed, it's basically like you do the remodeling in the house. It used to have 5 rooms, now it has 1. Does that make sense? So adjacent alveoli merge. Well, first of all, it reduces the surface of the respiratory membrane, very much decreasing the rate of the external respiration. External respiration. Top of that, it's really hard to exhale air from the lungs. Lungs are less elastic, so they do not recoil normally. Does that make sense? Since they're less elastic. And you have to use accessory muscles. By accessory muscles, scalise, for instance, sternocleidomastoid. Okay? So people with emphysema, they are tired just because they breathe. Due to constant hyperinflation, because think about this. If your respiratory membrane, if its surface is reduced, you will need to breathe in more oxygen. Since you can't normally exhale, that oxygen, that air, will stay in your lungs for an extended period of time, pressing on the diaphragm. Diaphragm gets flattened, gets weaker, the ventilation rate decreases. So people with emphysema will have progressively worse pulmonary ventilation. Does that make sense? On top of that, because of the damage to the alveolar walls, you're going to get damage to the pulmonary capillaries. Damage to the pulmonary capillaries means elevated pressure in the pulmonary circuit. Are you with me? Elevated pressure in the pulmonary circuit means right side cardiomyopathy, right side failure, congestive heart failure with, left side edema, systemic edema. Now, chronic bronchitis, inflammation of bronchi. Most frequently, the result of smoking, pollutants. If you ever wonder what real pollution looks like, Google Beijing or Shanghai, China. Okay. When I asked my nephew who went there for a year, he said, "Yep, that's true. People do wear masks during the daytime and it doesn't matter if you smoke or not. It doesn't really influence your risk of dying from lung cancer." So, since airways are obstructed by the mucus, ventilation rate decreases, gas exchange decreases, pulmonary infections go up. So basically, chronic bronchitis sets the stage for, say, pneumonias, frequent bacterial pneumonias. All these conditions, both emphysema and chronic bronchitis, treated mainly with bronchodilators like, the inhalers, various corticosteroids, and in severe cases, oxygen to increase the partial pressure of oxygen in the lungs. Asthma, I don't want to ask, those who have asthma know what I'm talking about. Yeah. Reversible chronic obstructive pulmonary disease. By reversible, I mean it's not with you all the time. I was lucky enough to have real asthma attack once in my life. That was enough. Lasted 3 days. That was terrible. I know what dyspnea is. I know what wheezing is. I know how scary it is to fall asleep thinking, am I going to wake up tomorrow? So that's pretty bad. And at that time, I wasn't diagnosed with asthma, so I didn't have the inhaler. It was pretty awful. Usually allergic. Okay? So, in most frequent cases, people are allergic to something, and allergy will cause asthma attack. However, in some folks, asthma can be triggered, basically can be idiopathic. So people will develop asthma attack without any obvious trigger, and it's especially dangerous if it happens during the night. My kid's classmate actually died of asthma while sleeping. He couldn't reach his inhaler. Yep. So it was too late. Now, one particular obstructive pulmonary disease that I wanted to talk about is cystic fibrosis. So it's a genetic disease, which is uniformly lethal. It's the most common lethal genetic disease in the United States and Canada. So in people with cystic fibrosis, normal chloride channel, shown on the left, is altered. by a single, I believe, single amino acid substitution. So that change, that mutation, makes this channel dysfunctional, so it doesn't move chloride ions, doesn't pump chloride ions to the outside, and that leads to the accumulation of the mucus in the various body sites, mainly lungs and lower respiratory tract, pancreas, and reproductive system. Now, accumulation of mucus in pancreatic ducts leads to indigestion, which is honestly a minor problem compared to the respiratory problems that cystic fibrosis patients experience. Accumulation of mucus, kind of schematically shown here, in the respiratory passages significantly reduces the pulmonary ventilation, leading to bacterial infections. So bacterial, let's talk about treatment, and then we will address the topic of bacterial infections. Mucolytics, mucus dissolving drugs, used to loosen the mucus. Chest percussion was shown to be quite effective, but technique has to be learned. The advantage is chest percussion can be learned by the relatives of the patient with cystic fibrosis. Does that make sense? And they can do the procedure at home. It was shown that inhalation of the hypertonic saline really helps to thin the mucus, so basically nebulizer is used to inhale the saline, loosen the mucus so it can go out. Now, the main problem is infections. And at some point, part of therapeutic approach to the cystic fibrosis was to routinely give patients antibiotics to prevent severe pneumonias. Although it helped, it led to somewhat, well, I don't want to say unexpected, but sort of unwished result. That two microorganisms that are associated with the most notorious pneumonias in patients with cystic fibrosis, Burkholderia malleae and Pseudomonas aeruginosa, developed an enormous degree of antibiotic resistance. I'm not talking resistance to one or two antibiotics. There are strains of Burkholderia malleae that are resistant to virtually every antibiotic that we have. Does that make sense? So, the main problem, so there is a treatment. You can actually kind of sort of cure this disease now by lung transplant. Okay? Now, the main problem with the lung transplant, well, there's a rejection, but, you know, there is a problem that can arise in days. Bacteria that I was talking about, they can linger on to different parts of respiratory tract. And it's kind of a lottery whether or not that new good lung will be infected by those bacteria. Now, imagine the level of complexity. So you have a patient who is sick. You treat this patient with a bunch of antibiotics to hopefully get rid of all infections. And then you put the new lungs into that patient and put that patient on the immunosuppressive therapy. And if there is a microorganism hiding somewhere in the respiratory tract, it's going to be a field day for that bacteria in terms of the immunosuppressive therapy, right? Immunity is gone, so it can replicate whatever it wants. Make sense? So that's a real risk in lung transplantation. Now, I didn't really follow through, and I kind of feel guilty about it. There was a story, a girl who had lung transplant due to cystic fibrosis developed a disseminated pneumonia caused by Burkholderia malii, and it was totally antibiotic resistant strain. Okay, now we always think about antibiotics, often think about antibiotics as some miracle drugs that we take and all bacteria just fall dead. In real life, what happens, antibiotics help us to either reduce the amount of bacteria or stop them from growing so immune system can deal with it. When the person is on immunosuppressive therapy, antibiotics will not be as effective. So this girl was desperate, because new lungs, infection with a resistant microorganism, no treatment options. But then scientists decided that they're going to do something else. There are viruses that infect bacteria, and they designed a cocktail of viruses that can actually get down this Burkholderia malii. I never followed through if that was successful, but my personal hunch, it should be, because lungs, it's an interesting site. Okay, that should work. At least it should buy them some time. In terms of the long-term treatment, that statement there is more like I must say it statement. What I mean by that. It's not an expert opinion, but a person who, I wasn't involved in gene therapy, but I have a fair amount of idea how it works. So imagine you have a bunch of cells. Forget about reproductive tract. Forget about indigestion. Let's try to fix lungs, okay? You have billions of cells. Does that make sense? In order to cure cystic fibrosis, or at least make it less severe, you need to replace a defective CFTR gene in all those billions of cells. Am I clear? Make sense? So all studies that I'm aware of gene therapy demonstrated the highest level of success was they reached 1% of target cells, which sucks, right? Because if now we have not 100 but 99% cells producing defective chloride channel, it's not really going to help, okay? So I personally, based on all decades of gene therapy before, I am not really a firm believer of gene therapy, like traditional one. Maybe some viral gene therapy may be successful, I don't know. We'll see. Okay. It's like every year we say it, and we were saying gene therapy for like last decade. Now, what happens with your respiratory system with age? Also, restrictive pulmonary diseases. We do not breathe underwater, as you all know, so we do not breathe in utero. When we're born, lungs begin to function. They go into complete functional state 2 weeks after birth. And newborns have the highest respiratory rate, which decreases progressively as we grow. So we reach our peak when we're young, and then with age, the efficiency of our respiration progressively decreases. Okay, it decreases because, say, mucus is not cleared as well as it used to. Lungs are not as elastic as they used to. Alveoli are normally enlarged. Okay? Chest wall becomes stiff. Now that all basically are components of different restrictive pulmonary diseases. The problem with restrictive disease is that we cannot inflate lungs because they are not elastic or something prevents them from doing so. The first that comes to mind is idiopathic pulmonary fibrosis. Let's break this name down. Fibrosis means a lot of fibrous tissue, right? Now, fibrous tissue, is it elastic? No, so you can't really expand the lungs. What does idiopathic means? Unknown origin, yes. I like this word because it sounds really cool and really smart, but it means we have no idea. Sarcoidosis, connective tissue disease, amyotrophic lateral sclerosis, paralysis of the muscles, quite obvious. Remember a gentleman named Stephen Hawking? He was on the ventilator 24/7 because he couldn't breathe. Obesity. Well, people who are morbidly obese have problems with inhalation. Scoliosis. Any kind of chest deformities. Okay? People have kyphosis and they hunch forward. Okay? The chest expansion is limited. In elderly, often costal cartilages that connect ribs to the sternum, they ossify. They become stiff. They cannot expand their chest. So those are all restrictive diseases. Disease that is not in the United States anymore, or actually somewhere in the almost eliminated from the planet, polio is basically one of the components is restrictive pulmonary disease. Patients who suffered from polio, many of them had to sleep in the iron lung. They could go about, during the daytime, they had to forcefully inspire and expire. But during the night, they had to sleep in a special machine that would breathe for them. Does that make sense? Now, a couple last diseases, I like them, especially tuberculosis. Not that I like to have it, but it's kind of exciting. So this is chest x-ray of patients with different tuberculosis. So you see diffuse inflammation of the lungs, more focused inflammation of the lungs. And this is really severe tuberculosis. You see how badly lungs are affected. All that gray-white staining, basically inflammatory foci in the lungs. Okay, so it's caused by a bacterium, which is respiratory transmitted. This bacterium is extremely infectious. Some estimates put that 1/3 to a half the world population are infected with tuberculosis. Not every person that's infected will develop clinical condition. Only about 5% of infected folks actually develop clinical conditions, so you may live till the very old age having bacterium and not knowing that you have it. Okay? Symptoms. Primary tuberculosis, low-grade fever, cough, maybe occasional night sweats, and then it usually becomes latent. Chronic pulmonary tuberculosis, night sweats, productive cough, green or bloody sputum, weight loss. When you fill out the form at the doctor's office and they ask you about night sweats, fever, weight loss, racking cough, green or bloody sputum, they look for tuberculosis. This infection is most common in crowded, poorly sanitated areas. It's a prison infection. In fact, the guidelines for people who work in prison or have been incarcerated, the guidelines for what is considered to be positive TB test are different from the general population because they are at the high risk for exposure. Does that make sense? Diagnostics, TB test. Everybody's familiar with what that is? Intradermal injection of antigen. Chest x-ray, There are some blood-based tests, antigenic tests. Here, for me, like now it's normal. Like I feel very comfortable not doing it every year. When I was in school in Russia, every year, every child goes through the TB test and chest X-ray, because the infection is very common, especially among the prison population. So every year we got tested for pulmonary tuberculosis and tuberculosis infection. Does that make sense? It's treatable. Antibiotics, very, very long course. Very long course. And the problem is there are plenty of antibiotic-resistant strains. There are strains that are totally resistant. Okay? And by the way, there is no efficient vaccine, which makes this disease even more fun. Now, lung cancer. Did I mention the book, The Emperor of All Maladies? Huge chapter on lung cancer and all the misdeeds of tobacco companies associated with it. So, majority of cancer deaths in North America from lung cancer. In females, I think it actually topples breast cancer. I'm not sure, they kind of go very close, but it's very important cause of death. Lung cancer is because of smoking. I'm sorry. Whoever tells you otherwise, they don't know what they're talking about. What does that mean? Now, you have to understand, there are people who will smoke their entire life and will die when they will be parachuting in Himalayan mountains at the age of 123. Okay, that's totally possible. And there can be people who are absolutely healthy, athletic, fit, blah, 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 and they will develop lung cancer at the age of 30. Both is possible, but both is rare. Clear? So smoking tremendously increases your risk of developing lung cancer. 3 main types: adenocarcinoma, squamous cell carcinoma, small cell carcinoma. The most aggressive, small cell carcinoma. Okay, very metastatically active. The problem with lung cancer, it's really hard to diagnose in the early stages because we don't do chest X-ray like every year, not anymore. So often when people show symptoms like bloody sputum, cough, shortness of breath, it's the 3rd, 4th stage. And at this point, and especially if it's 4th stage and it's metastatic cancer, there's not much you can do. Okay? I don't think that in the US it is recommended to go through the CT scans or chest X-rays regularly because of the radiation exposure. Now, the lack of metastasis, people can consider themselves lucky. And in this case, a part of lung can be removed. That's, by the way, I think I mentioned that God gave us paired organs for a reason. Did I say this phrase now? We were talking about transplantation. Oh, it was in micro class. We're talking about transplantation. And I mentioned that some people, they donate organs to complete strangers just because they match. And when I mentioned that idea, not that I was going to a friend of mine who's a physician, she said, God gave us paired organs for a reason. She was referring to kidneys and lungs. So if there is, God forbid, something wrong with one of your lungs, it can be removed, partially or completely, and you still have one lung. Okay. One of my college professors actually had one lung. Craziest story ever. You know what the particle accelerator is? He worked at the particle accelerator, and it's huge, right? So he stepped inside, and somebody turned it on, and he got pierced by a bunch of neutrons. So, like, you know, these particles, they fly at a, like, terrible speed. So his one lung was completely obliterated. So he had only one lung. Should I say that he was smoking like 2 packs a day? Very funny guy. So, if one lung is affected by cancer and it's diagnosed early, surgical removal helps. If there are metastases, radiation and chemotherapy. The problem with metastasis, of course, is that we never know where the next metastasis will occur, because they may not be noticeable on the CT scan. So, for a long time, it was basically a, what you call it, death. Speechless, thank you very much, death sentence. So you had maybe several months to live. But recent research into checkpoint inhibitors opened up new therapy. The guys that discovered checkpoint inhibitors got Nobel Prize last year. So what essentially these drugs do, they activate your T cells. So your T cells can't attack your tumor again. You might have seen the advertisements for Opdivo and Keytruda. I haven't put a copyright sign, so I won't get sued. You might have seen those advertisements on TV. So what they do now, they combine checkpoint inhibitors with a traditional chemotherapy. And that extends the lifespan of the cancer patients. Now, this is something I consider to be quite interesting. How do we assess the efficiency of the cancer therapy? So how do we say that, you know, antibiotic therapy is efficient? Somebody has an ear infection. What do we want to see? Complete clearance, right? With cancer, if we would want to see complete clearance, what would be our success rate in treatment? It would be like dismal, absolutely dismal. So in cancer research and in cancer therapy, usually what is looked at is survival beyond certain time frame. Does that make sense? So for instance, how many people diagnosed with a stage 4 lung cancer will be alive 5 years after the treatment started? Blah, blah, blah. Okay? That makes sense. Now, this is better. Because, obviously, if somebody has stage 4 lung cancer, hopes to eliminate the tumor are pretty slim. But if you can extend somebody's lifespan by 5 years, that's pretty good. Does that make sense? So we have like 5-year survival rate, 10-year survival rate, 15-year survival rate. Can you see a problem here? A complicating problem in that parameter. Why this parameter is not ideal? I mean, it's good. Think about different patients. Think about what can be different. One fundamental parameter between different patients. Very simple parameter. Age. So, not only, you know, if you treat someone who's 30, then giving this person an extra 5 years, it's good. You know, you should feel good. If you treat someone who's 80, I mean, it doesn't mean just let him die, right? But if a person is 80, has lung cancer, gets treated, and 2 years later dies of a heart attack, you're kind of in limbo. You don't know if your therapy would let him survive over 5 years. Does that make sense? So it's kind of a hard stuff. Another type of therapy, and that's, by the way, the image of the lung cancer. You see a gigantic tumor. So, another therapy for lung cancer, sometimes used, anti-angiogenic therapy. So your tumor cells, when they grow a tumor, they grow so fast that blood vessels cannot keep up. Does that make sense? So in the center of a tumor, you have really hypoxic environment, and cells start to die. That forms a called necrotic core. And tumor cells, they usually produce so-called angiogenic factors, proteins that stimulate the growth of blood vessels. So the tumor gets vascularized and receives all the oxygen that it needs. So it's a pretty successful therapeutic strategy to target angiogenic factors, so tumor will not be able to grow blood vessels and basically will suffocate. Okay? Now, a couple more things. It's kind of interesting to look at the incidence rate. Look at the males. It's peaked in the early 80s and then started to decline. You know, anti-tobacco advertisements and stuff. In females, it peaked around 2000s and then started to decline. I don't know if anyone did any research, but my thinking, you know, smoking in females became more and more socially acceptable. And then it just became not really cool. And when smoking is banned everywhere, from planes to all public places basically, it just becomes really inconvenient. Okay. Now, a couple last things. It's not going to be on the exam. Vaping. Is it safe? Surprisingly, we don't know. There is no substantial clinical data that would suggest that vaping is same as smoking, less dangerous than smoking, or more dangerous than smoking. Does that make sense? Just no data so far. In terms of nicotine, same effects. So it doesn't matter whether you smoke, whether you do nicotine patches, or you vape. If there is nicotine, same effects on the cardiovascular system and so on. Generally speaking, for the respiratory system, anything that burns and gets inhaled is bad. Whether it's tobacco, pot, or whatever chemical components are in the vaping juice. Okay? So, and I don't know if anyone smokes, but the sooner you quit, the better. Okay?